I got my current job as Director of Best Practices in 1993. And I would say until 2 years ago, what I did was do this. I developed specialized forms of treatment that would work within Kaiser, very specialized practice environment, and that had a good basis in the literature. And then I began to get like some weird dissonance and interference with my own model. Also versus the complexity of somebody like John Arden versus what's kind of in the best practices manual that we're trying to get all these clinicians to comply with. But kind of more importantly, this is one of the things that happened to me. There was a study done, a guy at the Oregon Health Sciences University got increasingly annoyed going to cocktail parties. He had been an FDA guy, and Turner is his name. And people would start talking to him about antidepressants and how, this tremendous body of literature supporting the efficacy of SSRIs. And he knew that there was a lot more in the FDA archives than had been published. So he got a subpoena and got all the studies, negative and positive, and then published a lit review of the whole McGill. And what he found was that studies that showed positive effects were 12 times more likely to have been published than studies finding negative effects. The implications of that is that the impression of efficacy of antidepressants is much, much higher than the research supports. And is that a conspiracy? I don't know. Patients said to me that conspiracy theories among American men now are as popular as hysteria was among women in the Victorian times. It could be, but it's also true that journals just like to publish positive studies. They don't want to publish negative studies. They're bad news. Who cares? Who wants to know what doesn't work? The effect of this, though, is considering the new studies, the effect size of antidepressants has been lowered basically at just one notch above placebo. That's not chopped liver. Placebos, are very powerful, and we all know sometimes antidepressants are just like seemingly a magic bullet. They're terrific. But on an aggregate evidence-based level, they have gone from being effective to being moderate or mildly effective. Kaiser now considers them mildly effective in our most recent national guideline. Most importantly for me, I began to encounter a whole other school of psychotherapy researchers, particularly Michael Lambert and John Norcross, who were leading a counter initiative in the AP Psychological Association. And they were pointing out that technique basically, if you look at complex variables in outcome, technique has almost a negligible effect. More important than technique is how much the therapist believes in the technique. If there's a high degree of coherence about belief on the therapist's part, it has more effect than whether two different people are both using the same manual. Second fact is that we are not good judges of outcome. We're slightly worse than chance in aggregate studies about when we're asked, how's the patient doing? The responses come in and we're slightly below 50% accurate. Many different methods are effective, which is very good news. Psychotherapy on the whole is more effective, for instance, than antidepressants. It has an effect size of about between 0.6 and 0.7. Antidepressants is about 0.5. And most therapists are good enough. Most of us produce good results most of the time. Bad news is that there is a significant cohort of people, and this is one of the reasons that the effect size of psychotherapy is actually lower than it might be, which we'll talk about later, is that psychotherapy can produce enduring negative results. This is after our colleague and friend Michael Lambert, who's been extremely helpful to us. And it's kind of, an estimate based on 30 years of doing psychotherapy outcome research on his part about what matters. Patients, the 500-pound gorilla. 40% of the variance is accounted by patient factors such as whether the patient's highly resistant, moderately resistant, or not that resistant. The patient's level of distress. Common factors are the next biggest factor. Common factors are things like confidentiality, establishing not just a positive relationship, but a relationship in which negatives can be brought up and worked on and to some extent worked through in the therapeutic relationship. Consistency, whether the therapist has generally a positive regard for the client. Those are common factors that characterize what psychotherapy is that not true of, basically unsuccessful ones. And you've got technique at 5%, and then you've got personal factors about the therapist's warmth, their ability to speak, to comprehend nonverbal cues, to interpret action, not just language, those kinds of things. So, I'm thinking, great, I've been promoting evidence-based treatment for 15 years, and where is this going to go? Another thing that came in for both John and myself at this point, John is trained also as a neuropsychologist. I'm not. I'm a clinical and research psychologist. But we started hanging out a lot more with neuroscientists, and to some extent from people who were interested in the brain from outside of our field, outside of psychology. John will take this up in much more detail later, but what is the hot thing in neuroscience right now, at least among the neuroscientists who are speaking to clinicians, is neuroplasticity, is the brain's ability to change and adapt in regard to experience, both external experience and internal experience, to transform experience into biology. So the model that emerges from this is a sense of a mind which is very much embodied. The mind is something that the body does in this view. It's not this kind of free-floating virtual thing that has kind of been the case in my experience, most of my professional career about the psychological view and the psychoanalytic and the CBT view of the mind, with these reifications like id and core beliefs, and where are those things?